Greetings of the day. I, Dr. Ashok Kumar, Professor and Head Department of Medicine, Santosh Medical College, will discuss today regarding diabetes mellitus overview and future. This is a very common topic which we are dealing in day-to-day clinical practice. The flow of my presentation would be: I'll start with introduction, epidemiology, classification of diabetes, type 1, 2, gestational diabetes mellitus, and other diagnostic criteria, complication, and treatment and summary of future therapy which are available to us. As we all know, diabetes mellitus refers to a group of common metabolic disorders that share the phenotype of hyperglycemia. It is caused by complex interaction of genetics and environmental factor, which we will discuss in subsequent slides. The common factors are reduced insulin secretion, decreased glucose utilization, and increased glucose production. This is a very important flow diagram which shows the typical sequence of insulin resistance and pancreatic beta cell dysfunction during development and progression of hyperglycemia in type 2 diabetes. In the normal state, there is euglycemia, there is normal plasma insulin, there is high insulin sensitivity is there. With the effect of genetic factor like ethnicity, gender, somatotype, expression of enzymes, transporters controlling energy metabolism, and environmental factors like dietary composition and amount, sedentary lifestyle, and coexisting disease condition and medication, that they all leads to insulin resistance, development of prediabetes, and causing beta cell dysfunction, in which what happened, there is a stage of prediabetes do occur, and euglycemia is gradually deranged. Plasma insulin levels are increased in order to compensate the hyperglycemia, and over the period of time sensitivity under the effect of genetic and environmental factor it is decreased. Then if there is a gross beta cell dysfunction, then we are arrive at a diagnosis of type 2 diabetes. Over the period of time there is occurrence of beta cell failure is there. Hyperglycemia is gradually increased, and over the period of time insulin sensitivity is decreased in complete beta cell failure. Then they occur microvascular and macrovascular complication of diabetes, which we will discuss in subsequent slides. We should always know the epidemiological data. As per the International Diabetic Federation, the world data shows there are 537 million adults in the age group of 20 to 79 years are living with diabetes. That is 1 in 10 persons. This number is predicted to rise to 643 million by 2030 and 784 million by 2045. Over 4 in 5, that is 81% adults with diabetes live in low and middle income countries like our countries. And diabetes is responsible for 6.7 million deaths in 2021. That is 1 in every 5 seconds. One person is die every 5 seconds due to diabetes. Diabetes caused at least US dollar $966 billion in health expenditure. That is huge amount of expenditure is being occurred when the patient is uh, when the patient is having diabetes, and the expenses occur due to the management of diabetes and related complication due to hospitalization. 541 million adults have impaired glucose tolerance, which places them at high risk of type 2 diabetes. Regarding Indian data, in our Indian subcontinent, 74 million adults are living with diabetes mellitus. This number is predicted to rise to 23 million by 2030 and 125 million by 2045. People with undiagnosed diabetes, that 40 millions. That is in our country, 1 in 2 adults are living with diabetes, which is unrecognized. This pictorial diagram shows you the various risk factors which are there, which causes patient to in the future to develop frank diabetes mellitus. That is obesity, smoking, stress due to day-to-day activity and lifestyle, consumption of fast food, and over the above genetic predisposition. This slide shows the basic classification of type 1 uh, diabetes, that is in four categories: type 1 diabetes, type 2 diabetes, gestational diabetes mellitus or GDM, and diabetes mellitus associated with other condition or causes. Type 1 is mainly due to beta cell destruction, usually leading to absolute insulin deficiency, and type 2 diabetes is due to progressive insulin secretory defect on the background of insulin resistance, and gestational diabetes mellitus, which is diabetes which is diagnosed during pregnancy and which is not clear over diabetes. Diabetes mellitus associated with other condition or causes will have some uh, words regarding this entity. This table shows the characteristics difference between the type 1 and type 2 diabetes. And as you can see, 90% of patients are suffering from type 2 diabetes mellitus. Age is more than 40 in type 2 and usually less than 30 or younger in type 1 diabetes. Pancreatic function is totally disturbed in type 1. In type 2, there is insulin is low, normal, or can be high in cases of insulin resistance. Pathogenesis of type 1 diabetes is usually autoimmune, and there is a defect in insulin secretion, insulin resistance to insulin, or increased hepatic glucose output in type 2 diabetes mellitus. There is strong family history in type 2 diabetes mellitus, but in type 1, it is generally not strong. Obesity is common in type 2 diabetes mellitus, which is uncommon in type 1, and ketoacidosis is often present in type 1, and clinically, type 1 diabetes is present with moderate to severe symptom, and polydipsia, polyuria, and polyphagia, fatigue, weight loss, and ketoacidosis. And the treatment is mainly insulin diet and exercise in case of type 1, while dietary modification, exercise, and oral anti-diabetic drugs are the mainstay of treatment in type 2 diabetes mellitus. Prediabetes is a condition which poses the person to, if it is present, that poses the person to suffer with diabetes mellitus in later part of the life. So we can say it is a category of increased risk of diabetes, in which if we do the if we it can be defined as fasting blood glucose level in between 100 to 125 milligram percent, or 2 hour postprandial glucose or 75 OGGT. The values of if the RBS are 140 to 199, then patient can be labeled as prediabetes, or glycated HbA1c is if in the range of 5.7 to 6.4, then we can say patient is suffering from prediabetes, which poses them to develop frank diabetes mellitus in later life. Next is uh, criteria for diagnosis of diabetes mellitus. There are three criteria, and like HbA1c level more than 6.5%, and for this test should be performed in a laboratory using a method that is NGSP certified and standard to DCCT assay, or fasting blood glucose level more than 126 milligram, and 2 hour postprandial glucose is more than 200 milligram during OGTT as per the WHO criteria. Or if a patient who are having classical symptoms of hyperglycemia like polyphagia, polydipsia, or polyuria, if we find a random plasma glucose of more than 200 milligram, then we can label the patient is suffering from type 2 diabetes mellitus. Now we'll discuss type 1 and type 2 diabetes mellitus one by one. Type 1 diabetes was previously called insulin dependent diabetes, or also called juvenile onset diabetes, as is often become in childhood. Type 1 diabetes is characterized by destruction of pancreatic beta cell leading to absolute insulin deficiency, and it is thought that combined genetic, immunological, and possibly environmental factors contribute to beta cell dysfunction. Coming to the pathology of type 1 diabetes, then there are effect of genetic and as well as environmental factor. In genetic factor, it is generally accepted that genetic susceptibility is an underlying factor in development of type 1 diabetes. People do not inherit type 1 diabetes itself, rather they inherit the genetic predisposition or tendency toward developing of type 1 diabetes. This genetic tendency has been found in patients with certain HLA, that is human leukocyte antigen types. One proposal is that reduced exposure to microorganisms in early childhood limit maturation of immune system and increase susceptibility to autoimmune disease, also known as the hygiene hypothesis. Stress may precipitate type 1 diabetes by stimulating the secretion of counter-regulatory hormone and possibly by modulating immune activity. Dietary factors may also be important. Various nitrosamine found to be in smoke and cured meat and coffee have been proposed as a diabetogenic toxins. Clinical feature of diabetes or type 1 diabetes we can say as polyuria. It's caused by osmotic diuresis secondary to hyperglycemia. Thirst, increased thirst, that is response to the hyperosmolar state and dehydration, leading to increased thirst. Fatigue and weakness may be caused by muscle wasting from the catabolic state of insulin deficiency, hypovolemia, and hypokalemia. And there is extreme hunger, or you can say polyphagia with unintended weight loss is there because of uh, catabolic effect of insulin deficiency. Muscle cramps is usually caused by electrolyte imbalance associated with insulin deficiency as well as hyperglycemia or polyuria. Blood vision, glucose and its metabolite cause osmotic swelling of lens, altering its normal focal length, and feeling numbness or tingling in feet, that is development of diabetic neuropathy in patient with long-standing diabetes mellitus. Diagnosis usually occur before the age of 30, and incidence is 12 to 14 cases per lakh population younger than 20 years and one case per 500 people younger than 16 years. And diagnostic criteria we already been discussed, that is fasting more than 126 on two separate tests and HbA1c more than 6.5 or postprandial or OGTT level more than 200 milligram can be labeled as diabetes mellitus. Certain immunological marker can be uh, tested for the predisposition of type 1 diabetes or attributing to some certain etiologies like insulin cell autoantibodies are the composite of several autoantibodies that act at pancreatic islet molecules such as glutamic acid, decarboxylase, insulin, and IA2/IC8 5112 and serve as a marker of autoimmune process of type 1 diabetes. Testing for ICA can be useful in classifying the type of diabetes as type 1 and identifying non-diabetic individual at a risk of developing type 1 diabetes mellitus. As we know that in the pathology there is absolute insulin deficiency is there, then it means that only insulin is the treatment of choice in patient of type 1 diabetes mellitus. We all should know, and insulin therapy is a, is given by various available insulin in form of rapid acting insulin, short acting insulin, or intermediate acting insulin. The rapid acting insulin is used as a bolus dose and the action onset in 15 minutes with peak action in 30 to 90 minutes, usually given 15 minutes prior to meal. Drugs are Humalog or Lispro, Novolog or Aspart, Epidra or Glulisine. There are three types of rapid acting insulin are there. Yeah, yeah, ultra fast acting insulin you can say. Short acting insulin are onset within 30 minutes and with peak around 2 to 4 hours. Drugs are available are regular insulin or Vellucin for the use in the insulin pump. And certain intermediately acting insulin like which action 1 to 2 hours but peak action in 4 to 6 hours. Drugs are like NPH and action can be prolonged up to 12 hours. There are some long-acting insulins are also available, which are usually given around bedtime to control fasting, hyperglycemia. Action is roughly onset is in 1 to 2 hours, but it is sustained around 17 to 24 hours. Drugs are like insulin glargine, commercially available name is Lentus, and Levemir, insulin Datamir is there. Next type of insulin which can be used in type 1 diabetes mellitus. Premix insulin is a combination of specific proportion of intermediate acting and short acting in one bottle or insulin pen. These products are generally taken 2 or 3 times a day before mealtime, and action of onset is 30 minutes to 4 hours with sustained action up to 24 hours. The various combinations are in the percentage of humulin 70-30, novolin 70-30, humulin 15-50, and there is a combination of short-acting insulin as well as uh, NPH in the various proportion 50-50. Along with the insulin treatment, we have to advise the patient to stick to the dietary plan, which is usually diabetic diet, in which avoidance of carbohydrate or direct sugar is totally avoidable. We should always encourage the patient to do the physical activity or exercise at least 30 to 45 minutes per day for at least 5 times a week. And patient has to monitor or regularly check up of his blood sugar and keep to the blood sugar in the normal range 80 to 140 milligram at any point of time. And we have to also control the blood pressure, monitor cholesterol level, and the future therapies like transplantation of pancreas and transplantation of islet cells are also being uh, tested and or under research. Certain drugs are found to be uh, active in found to be helpful in prevention of type 1 diabetes, like use of cyclosporin drug, but anti-C3 antibody like teplizumab. But these are the still in research phase. And some diet, in some research, it has been found that breastfeeding decreases the risk of developing of type 1 diabetes later in the life. And giving children 2000 IU of vitamin D during their first year of life is associated with reduced risk of type 1 diabetes. But the causal relationship is obscure as of now. Now we will discuss type 2 diabetes mellitus. It was previously referred to as non-insulin dependent diabetes mellitus or adult onset diabetes. It is more complex condition than type 1 diabetes as there is a combination of resistance to action of insulin in the liver and muscle together with impaired pancreatic beta cell function leading to relative insulin deficiency. Insulin resistance appears to come first and leads to elevated insulin secretion in order to maintain normal blood glucose level as we have already seen in figure. However, in susceptible individuals, the pancreatic beta cell are unable to sustain the increased demand for insulin and slowly progressive insulin deficiency develops. So, as we can see here, the mainly two dual metabolic abnormality in type 2 diabetes mellitus is seen, that is insulin resistance as well as insulin deficiency. As you can see, what happened during insulin resistance, there is decreased glucose uptake is there, unrestrained lipolysis is there because insulin is not functioning to the uh, target organs, and there is excessive hepatic glucose output via the insulin resistance in the liver. And there is insulin deficiency because of the decreased insulin secretion by the pancreatic beta cell, which we are, over the period of time are due to apoptotic process are decreasing in the number. So this table shows the natural history of type 2 diabetes mellitus, as we already seen in the previous slides also. So uh, zero shows the development of diabetes. Prior to that, there is the occurrence of impaired glucose tolerance, and the as you can we can see before the development diabetes, there is a uh, beta cell functions are normal on the tune of 100% before development of diabetes, and over the period of time, when the patient develops diabetes mellitus, the beta cell function are decreasing. And as you can see, because of beta cell function decreasing, there is development of insulin resistance are high. The effect of these two things are there. Blood glucose is quietly maintained uh, up to the 5 to 6 year prior to development diabetes because of the hyperinsulinemia and compensatory insulin secretions, leading to normal euglycemia to a certain extent. Then patient develop impaired glucose tolerance, and then patient when the hyperinsulinemia or insulin resistance is getting very high, then frank diabetes development is there, and then over the and later part of the life, both fasting glycemia and post-meal glucose are increasing in the later part of the life. And the key factor are environmental factor and development of obesity or insulin resistance are there. So there is beta cell functions are over a period of time are decreasing, and insulin resistance are increasing. So there is development of diabetes because of these. So we'll discuss insulin resistance one by one. It refers to decreased insulin sensitivity to insulin. Normally, insulin bind to certain receptor on cell surface and initiate a series of reactions involving glucose metabolism. In type 2 diabetes mellitus, these intracellular reactions are diminished, thus rendering insulin less effective at stimulating glucose uptake by tissue and at regulating release by the liver. The exact mechanism that leads to insulin resistance and impaired insulin secretions in type 2 diabetes mellitus are still mysterious, although genetic factors are thought to play a role. Metabolic syndrome is also known as insulin resistance syndrome, in which there is a glucose intolerance is there. There is occurrence of dyslipidemia because of presence of insulin resistance, in which we can see high triglyceride or low HDL, and cardiovascular uh, diseases are there. These poses the insulin resistance poses patient to suffer from cardiovascular disease. There is also development of obesity because of this, and development of polycystic ovarian syndrome in females can be there, and development of hypertension. So insulin resistance can pose a person, if it is there, to the various metabolic dysfunction or metabolic effect of insulin resistance are there. The second thing is that impaired pancreatic beta cell function over the period of time in type 2 diabetes mellitus. The insulin secretion and sensitivity are interrelated. In type 2 diabetes mellitus, insulin secretion initially increases in response to insulin resistance to maintain normal glucose tolerance. Initially, the insulin secretory defect is mild and selectively involved glucose-stimulated insulin secretion. Eventually, the insulin secretory defect progressed to a state of grossly inadequate insulin secretion. The assumption is that second genetic defect, superimposed insulin resistance, leads to beta cell failure that leads to development of frank diabetes mellitus in the later part of life. Recently, the ominous octet in type 2 diabetes mellitus pathogenesis has been emerged. The center of which is hyperglycemia, which is caused by various eight factors like decreased incretin effect, increased glucose, increased lipolysis, increased glucose reabsorption, decreased utilization by muscle, there is occurrence of neurotransmitter dysfunction, and increased hepatic glucose output, and increased glucagon secretion, and impaired insulin secretions are also there. So as the research emerges, this ominous octet show the way the various other metabolic or neurological dysfunction occurs, which causes hyperglycemia to occur, and these also open the Pandora of boxes of various therapy which can be offered to the patient depending on the involvement of various parts of this ominous octet. Whenever we deal with the patient of type 2 diabetes mellitus, we also should know the risk factor of type 2 diabetes mellitus. That is, we have to ask the patient regarding the family history of diabetes, parent or sibling with type 2 diabetes mellitus. If the both parents have type 2 diabetes mellitus, the risk approaches to 40%. If the BMI of the patient, that is patient is obese, more than 25 kg per meter square is their BMI, then patient is can develop risk of diabetes in the later part of life. Habitual physical inactivity. The patient is having a lifestyle which poses him to be physically inactive, then he or she may develop diabetes mellitus in later life. Certain race or ethnicity are found to be Risk factor for developing of diabetes mellitus, as we have written here: African American, Latino, Native American, Asian American, or Pacific Islander. If there is history of GDM or delivery of baby more than 4 kg in a female, the female becomes a risk factor for developing diabetes. If there is history of GDM is present, or large size babies delivered in the past. Hypertension, if the BP is more than 140 by 90, HDL cholesterol level less than 35, or TG level more than 250 are also risk factor of diabetes mellitus. Polycystic ovarian syndrome, history of vascular disease, these are all risk factor of type 2 diabetes mellitus, which we all should know. Now comes to the treatment of diabetes mellitus. Diabetes mellitus treatment should begin with medical nutrition therapy, and exercise treatment to increase insulin sensitivity and promote weight loss should always also be instituted. We'll discuss medical nutrition therapy in later slides. Pharmacological approaches to the management of type 2 diabetes mellitus include oral glucose lowering agent, insulin, and other agent that improves glucose control. Type 2 diabetes mellitus is a progressive disorder, requires multiple therapeutic agents and offer insulin. So it's not a single line approach or single person approach. The treatment of type 2 diabetes mellitus is always been a multidisciplinary approach in which help in various specialty also will be taken depending on the presence of complication or requirement of the person. First of all, we have to educate the patient regarding the management, because once diabetes mellitus is developed, it is a lifelong disease. The hyperglycemia will always remain with the patient if patient is not going to control his or her insulin by various activities. So there is apart from the dietary restrictions of carbohydrate and glucose and exercise program for the management of diabetes in the patient, they always should be self-monitoring of the blood glucose. That is, awareness of blood glucose level should always be there, and estimation of urine ketone monitoring should be there, especially in type 1 diabetes mellitus or sometimes in type 2 diabetes mellitus, because uh, ketoacidosis is a very acute complication of diabetes, which can always be there when there is very high blood glucose are there. Patients should always be educated regarding insulin administration, because when the blood insulin is secreted very low in type 2 diabetes mellitus, or blood glucose is not adequately controlled even after oral hypoglycemic agent, then we have to administer insulin in the type 2 diabetes mellitus also. So patients should know regarding the insulin therapy and insulin preparation, types, time of course of action, as we already discussed, selecting and rotating the injection site, complication of insulin therapy, that is the insulin lipodystrophy, local and systemic allergic reaction to uh, some constituents of insulin. And we always patients should be always be educated regarding the guidelines for diabetes management during illness, because wherever any acute illness occurs, the requirement of insulin is always increase. If it is insulin or OHA are not increased on time, then the acute illness is not going to recover in time and may further complicate because of the hyperglycemia. So management of hypoglycemia has to be done. We have to advise the patient to foot on skincare, diabetes management before, during, and after exercise, and risk factor modifying various activities should be there. Now, regarding medical nutrition therapy, which is very keystone in the management of diabetes mellitus of both type 1 as well as type 2 diabetes mellitus, in which there is optimal coordination of caloric intake with other aspects of diabetes therapy like insulin, exercise, and weight loss. ADA, that is American Diabetic Association, has issued recommendation of three types of MNT that is for primary prevention, secondary prevention, tertiary prevention. Primary prevention measures the MNT are directed at preventing or delaying the onset of type 2 diabetes mellitus in high risk individual, as we have the category we already have discussed. That is obese or pre-diabetes, or by promoting weight reduction. So medical nutrition therapy has a very important aspect in primary prevention. In secondary prevention, that is, it measures it is directed at preventing or delaying diabetes related complication in diabetic individual by improving glycemic control. Prevention measure of MNT are directed at managing diabetes-related complications like CVD, nephropathy, etc. in diabetic individual. Now, what are the nutrition? We should always know that what are the recommendation in terms of nutrition in patient with adult patient with diabetes. First of all, fat. The content of fat should be 20 to 30% of total caloric intake, and it should be the saturated fat should be less than 7% of total calorie, and less than 200 milligram per day of dietary cholesterol should be taken. Two or more serving of fish per week provide omega-3 polyunsaturated acid can be encouraged patient who can take non-vegetarian diet, and there should be minimal trans fat consumption in the diet of person. Regarding diet, in carbohydrate in diet, 45 to 65% of total caloric intake, that is low carbohydrate diets are not recommended, and carbohydrate consumption should be limited to 45 to 65%. Amount or type of carbohydrate important. That is amount of carbohydrate determined by estimating grams of carbohydrate in diet. That is, and glycemic index reflects how consumption of a particular food affect the blood glucose level. So usually the high glycemic index carbohydrate should be avoided because they can cause rapidly rise in the blood glucose level. Sucrose containing food may be consumed with adjustment in insulin doses. Regarding protein, the consumption of protein should be limited to 10 to 30% of total caloric intake, and high protein diets are not usually recommended, especially in chronic kidney disorder or patient with diabetic nephropathy. Other component like fiber containing food may reduce postprandial glucose, and non-nutrient sweetener can be advisable. And alcohol and smoking should be avoided because they can cause impairment of blood glucose control by the rest of the methods which we have already discussed. Exercise is also, apart from the diet, and exercise is also a cornerstone in the management of diabetes. For individuals with type 1 and type 2 diabetes mellitus, exercise is also useful for lowering plasma glucose during and following exercise and increasing insulin sensitivity. In a patient with diabetes mellitus, ADA recommends 150 minutes of per week distributed over the period of 3 to 5 days of aerobic physical activity. In patients with type 2 diabetes mellitus, the exercise regime should also include resistance training, that is weightlifting. Now coming to the therapy for diabetes mellitus type 2, though we are using glucose lowering therapy, yeah, or we can say oral hypoglycemic agents are being used. Sulfonylureas are the most important, and initials it has been used in uh, since long time. And glucose lowering agent, one is sulfonylurea. The primary action is directly stimulating the pancreas to secrete insulin, that is also known as insulin secretory GOX. Therefore, a functioning pancreas is necessary for these agents to be effective, and they cannot be used in patients with type 1 diabetes mellitus because there is no pancreatic beta cells are there to this drugs to be for the action. These agents improve insulin action at cellular level and may also directly decrease glucose production by liver. The sulfonylurea can be divided into first generation or second generation. First generation sulfonylureas are first generation sulfonylureas now currently are not in use. They are having some serious side effect. And nowadays we are using second generation sulfonylureas. The names of which are glipizide, glyburide, glimepiride, glyclazide. Biguanides are the first drug which we all know, metformin or fenformin. Fenformin is not being used because of the serious side effect and producing lactic acidosis, but metformin is there. It produces antidiabetic effect by facilitating insulin action on peripheral receptor side. Therefore, it can be used only in the presence of insulin. There is some evidence that it also impairs glucose absorption by the gut and inhibit hepatic glucogenesis, leading to the decrease blood glucose levels. So it has multiple effect in managing blood glucose levels. It has increased susceptibility for lactic acidosis, but as we have discussed, it is less than the fenformin. It is contraindicated in the patient with impaired renal or hepatic function or in patient who drinks alcohol in excessive amount. Regarding renal impairment, it is usually avoided when the serum creatinine level is more than 1.5. Next drugs are alpha glucosidase inhibitor. They work by delaying the absorption of glucose in the intestinal system, resulting in lower postprandial blood glucose level. They must be taken immediately before a meal, making therapeutic adherence. And side effects are diarrhea and flatulence because of non-absorption of carbohydrate in the gut, leading to uh, some flatulence and sometimes diarrhea. Drugs are acarbose and voglibose. Next drugs are in the use are thiazolidinediones are there. They are causing enhanced insulin action at the receptor site without increasing insulin secretion from the beta cell or the pancreas. Sometimes they may have affect liver function. Drugs are pioglitazones or rosiglitazone. Next drugs are maglutinides. They lower the blood glucose level by stimulating insulin release or from the pancreatic beta cell. So these are also milder drugs, milder uh, insulin secretagogues are there as compared to sulfonylurea. Its effectiveness depends on the presence of functioning beta cell. The drugs are rapaglinide and natiglinides. There are some newer oral or injectable hypoglycemic agents are there. DPP-4 inhibitor drugs like sitagliptin, saxagliptin, vildagliptin, or linagliptin, and other drugs are GLP-1 analogs have been found to be particularly effective in helping to improve blood glucose levels by stimulating insulin secretion and helping weight loss. Drugs are dulaglutides, exenatide, liraglutide, and lexinatides. After the therapies, now we should have some words regarding the prevention of diabetes mellitus type 2. As the ID already said, the lifestyle modification and pharmacological agents prevent or delay the onset of diabetes mellitus. Weight loss of 7% of body weight and increasing physical activity to at least 150 minutes per week of moderate activity such as walking, running, jogging. The diabetes prevention program demonstrated the intensive change in lifestyle, that is, diet and exercise for 30 minutes per day, 5 times per week in individual with delayed the delayed the development of diabetes mellitus by 58% and metformin prevented or delayed diabetes by 31%. So, as per this study of diabetes prevention program, so they have some effect in delaying the development of diabetes by various percentage, as we have discussed. Now comes the gestational diabetes mellitus. It refers to hyperglycemia occurring for the first time during pregnancy. During normal pregnancy, insulin sensitivity is reduced through the action of placental hormone like human placental lactose, estrogen, and cortisol, and this effect causes affect the glucose tolerance. Most women revert to normal glucose tolerance postpartum, but have a substantial risk in the tune of 30 to 60% of developing diabetes mellitus in later part of life. So, in nutshell, this hyperglycemia occurs for the first time during pregnancy, and after pregnancy, most of the human reverts to normal euglycemic state, but this state still poses the substantial developing of uh, diabetes mellitus later part of the life as well as in their offerings also. Now, regarding the recommendation of diabetes in diabetes in pregnancy, or when how we are going to assess or detect or make a diagnosis of gestational diabetes in pregnancy. So we have to screen for undiagnosed type 2 diabetes mellitus at the first prenatal visit in those with the risk factor using standard diagnostic criteria as we have discussed. Screen for GDM at 24 to 28 week of gestation in pregnant women not previously known to have diabetes. Screen women with GDM for persistent diabetes at 6 to 12 week postpartum using OGTT and non-pregnancy diagnostic criteria. Women with history of GDM should have lifelong screening for development of diabetes or pre-diabetes at least every 3 years. And further research is needed to establish a uniform approach of diagnosing GDM. Treatment of GDM is quite simple: dietary and lifestyle modification in terms of exercise and insulin therapy for the control of diabetes during pregnancy. So that's safe delivery and euglycemic delivery of the female can be achieved. Other rare causes of which can be cause diabetes are the genetic defect in beta cell function, genetic defect of insulin action like laparoscopism, lipodystrophies, pancreatic disease like pancreatitis, pancreatectomy, neoplastic diseases, cystic fibrosis, and fibrocalculous pancreatopathy. Excess endogen, some genetic condition like which causes excess endogenous production of hormone antagonist to insulin like excessive growth hormone, as in case of acromegaly, glucocorticoid, Cushing syndrome, catecholamine in cases of pheochromocytoma, thyroid hormones as in cases of thyrotoxicosis, which can causes hyperglycemia by virtue of their other effect, other metabolic effect. Sometimes drug-induced hyperglycemia is also seen in cases patients who are taking corticosteroid, thiazide diuretic, or phenytoin. Certain viral infection poses the development of hyperglycemia or diabetes in later life, like congenital rubella or mumps. Uncommon forms of inherited diabetes are also been there, and sometimes diabetes is associated with the presence of genetic syndrome like Down syndrome, Klinefelter syndrome, or Turner syndrome. Few words regarding the acute complication of diabetes mellitus. There are three acute complications: hypoglycemia, in which blood glucose level are becomes low because of the use of therapies like oral hypoglycemic agent or insulin. The risk factors are patient if the person is not taking adequate meal or doing excessive exercise or dose of drug missed, then patient may be at the risk of development of hypoglycemia, which should be immediately treated. And next is diabetic ketoacidosis and hyperosmolar hypoglycemic states, in which blood glucose are very high, leading to development of acidosis as well as ketone formation in the body, and sensorium may be altered. To name long-term complication of diabetes, we all should know there are other complications of diabetes like microvascular complication, eye disease, retinopathy, macular edema, neuropathy. In all type of neuropathies are there: motor, mono or neuropathy or autonomic neuropathy can be there in the patient with the long-term suffering from long-term diabetes mellitus, and nephropathy or end-stage kidney disease can be there. Next is the macrovascular complication, coronary artery disease like non-acetylation microinfarction or acute microinfarction, peripheral artery disease, cerebrovascular disease can be uh, complications of macrovascular complication of diabetes mellitus. Other complication like gastrointestinal complications, patient may be suffered from recurrent diarrhea because of the autonomic neuropathy. Genitourinary disturbance like uropathy, sexual disturbance, or recurrent UTIs, or in uncontrolled diabetes mellitus. Dermatological like protracted wound healing and skin ulcer can be there. Infectious complication, development of early cataract, glaucoma, periodontal disease can be the other complication of diabetes mellitus. This pictorial diagram taken from the 2021 ADA Clinical Practice Committee, in which there is the treatment guidelines has been given. How should we approach to the patient of type 2 diabetes mellitus with their therapy? So they have recommended the first line therapies is metformin, and depending on the presence of high risk or established complication like atherosclerotic vascular disease, CKD, or heart failure, then we have to offer therapy, various available therapy to the patient. Now, what are the guidelines for ongoing medical care for the patient of diabetes mellitus? As we all know, we all came to know that diabetes mellitus is a lifelong disease, and patient requires lifelong medical care. So we always should educate the patient regarding the what are the various ongoing complications can be there, and which can be prevented at timely intervention in the person who are suffering from type 2 diabetes mellitus. Patients should know the self-monitoring of blood glucose and individual frequency, like pre-prandial, post-prandial, 2 hours or sometimes random, or sometimes when the patient is having symptoms of hypoglycemia, like cold sweating, increased hunger, and palpitations, then we should always encourage to do the self-monitoring of blood glucose in these circumstances. That is blood glucose monitoring for control of diabetes, as well as to see the complication of diabetes in terms of hypoglycemia. HbA1c testing is which shows the long-term control of diabetes. For it should be repeated for 2 to 4 times per year. Patient education should be there in diabetes mellitus. It should be annually. Medical nutrition therapy and education should be done annually. And eye examination, annual eye examination recommended. Foot examination at least 1 to 2 times per year by physician or by surgeon, or daily by patient, where they have to see his foot, because when the patient develops diabetic neuropathy, apart from patient is developing painful one, the painless neuropathy or tingling numbness is there, then patient may have recurrent trauma, which can be unknown to the patient, and patient may develop various complications. Can be uh, limb can be affected. Sometimes an amputation can be should an amputation can be there if not seen properly by the patient. Screening of diabetic nephropathy, that is annual checkup in terms of urine microalbuminuria should be done there. Blood pressure measurement should be done whenever patient report to the physician, or quarterly. Lipid profile and serum creatinine clearance should be annual, and patient should be advised to do the prophylactic immunization of influenza and pneumococcal vaccination, and consider antiplatelet therapy in patients who are at the high risk of developing cardiovascular uh, complications. This pictorial diagram shows the present therapy, as well as what are the future possible other future therapies which can be offered to the patient. As we already gone through the Omnis octet, the present therapies are alpha glucosidase inhibitor, which causes slow carbohydrate digestion; GLP receptor agonist, which causes enhanced incretin effect; DPP4 inhibitors are there, which also causes enhanced incretin effect; sulfonylurea, maglutide, they stimulate insulin secretion by the pancreas; metformin causes insulin counters insulin resistance and reduce glucose production by the hepatic liver. Insulin has multiple effects, like increasing glucose uptake, decrease glucose output, and decrease lipolysis, causing the uh, ultimately decrease blood glucose. Thiazolidinones causes increased insulin sensitivity in nutshell, and SGLT2 inhibitors causes that they are also the newer drugs which causing glucose-uric effect through the kidney. So these are the present therapies in for the management of type 2 diabetes mellitus. The possible future therapies are they act at various levels, as the one target can be diet, the supplementation with prebiotic and probiotic food, which can alter the gut microbiome, may lead to the hypoglycemic effect. Newer SGLT1 and SGLT2 1 and 2 inhibitor, they delay the glucose absorption in the gut. And in the brain, certain agent like satiety inducing agent, which can reduce adiposity, that is analog of GLP-1, PYY, oxyntomodulin, they can cause satiety inducing agent. Patient may have decreased hunger and may have that effect, because intake of food is limited. It may leads to low blood glucose level. Insulin incretin mimics can act on both in the pancreas as well as brain, and small molecule receptor antagonist, they enhance incretin effect, that is oral GLP-1 agonist, hybrid and chimeric peptides are also been there. Certain insulin-tropic agent enhance insulin secretion. For example, beta cell mitochondrial stimulate, fatty acid receptor agonist, glucokinase activator, and glucagon secretion inhibition agent like GLP-1 receptor agonist are under pipeline. Tissue selective and smart insulins are under the investigation in the pipeline, which can in which we can have controlled insulin availability. Glucagon receptor antagonist, they reduce the effect of glucagon, which leads to the lower blood glucose. Direct effect of hepatic glucose production and stimulant of muscle glucose uptake and metabolism. Some AMPK activators are under being investigated. Small molecule insulin mimetics initiate or can enhance the insulin action. Certain adipokine analogs are also being investigated, which acts on the lipid cells, and novel insulin delivery routes like oral buccal and skin and other routes which can control the blood glucose, and novel SGLT2 inhibitors may have increased glucose-uric effect are under uh, research, and they are the possible future therapy for control of blood glucose in diabetes mellitus patients. So after future therapy, we should know the some criteria for testing of diabetes in asymptomatic adult individual. Those who are symptomatic, that is, they have classical symptoms of diabetes mellitus like polyuria, polydipsia, or polyphasia. Certain individuals are most of the many patient person are still asymptomatic, and diagnosis are to be done depending on their uh, features. So, person who are physically inactive, person who are the first degree relative of diabetes, they have high risk ethnicity. Women who delivered baby more than 9 pound or 4 kg or diagnosed with GDM, person who are hypertension, who are dyslipidemia, women with polycystic ovarian syndrome and history of CVD. In the absence of the above criteria, testing of diabetes mellitus should begin at the age of 45 years. So this, if there these even if these risk factors are not there, when the patient achieves the age of 45, he should be screened for development of diabetes mellitus. In children, testing for type 2 diabetes mellitus in asymptomatic children, the criteria is BMI is if the BMI is more than 85th percentile for age and sex, weight for height is more than 85th percentile or weight more than 120% of ideal for height, they should be screened for diabetes mellitus, plus family history, ethnicity, sign of insulin resistance, and maternal history of diabetes or GDM during the child's gestation. And this screening should be done at the age of 10 years or at onset of puberty if the puberty occurred younger age. And it should be repeated every 3 years in the patient who are children who are having asymptomatic and having risk factor of developing diabetes mellitus in later part of the life. To summarize, diabetes is one of the most challenging health problems globally. The burden of disease is tremendous, and conventional drugs are effective, but they have some drawbacks also. And various emerging therapies are also being investigated, like leptin treatment, mucoid acid delivery, gene treatment, nanotechnology, and some vaccines are under being investigated for the treatment of diabetes mellitus. Thank you very much.